drug use, and then we also have some definition of terms. We went to what psychoactive substances were, and we discussed other things about brain communication and how substances, affect the brain. And last time we also discussed about stigma, how it comes about, and what what we can do to reduce stigma amongst our own community or in our societies. Today we are on module 5. As I said earlier, this module is the last for course 1, and we are going to be looking at having a comprehensive overview of how what psychoactive substances are, and we'll also be looking at the short and the long-term effects of these psychoactive substances, how they affect or they operate in our own communities, and also we're looking at how psychoactive substances affect the family system. Yes, but before we go into the objectives, we'll be looking at the reflective exercises we had in the last presentation. You recall that when Beatrice ended her presentation, there were questions that we asked, and we asked to jot them in our journals and also to think about them right, and to present. We want to hear our views, and if we have actually carried out the assignment, we want 1 or 2 people to share with us what they have written down. And the first one is, are you surprised by anything you've heard so far, as you go through this course 1? And then the second question is, are you having trouble accepting a chronic disease model of addiction? As some people still have questions and trouble, and they find it difficult to agree, particularly among the religious ones, in my own society. And then has your thinking changed in any way? So please, I would like maybe 1 or 2 people to share with us what are their responses to these reflective exercises, if we have actually carried them out. Can anyone share briefly, just a minute?
Yes, I want to share my benefit on stigmatization.
Okay.
Usually we have been avoiding addicts as dangerous people. You don't allow them, don't do anything with them, but from this lesson I've understood that that's not the best approach to it. There are better people we can have.
That's very interesting. Thank you very much for sharing yourself. Does anyone identify with him? Does anyone identify with him? Who else wants to share what they have written down or their thoughts about these questions? You can shout any of the questions, please.
Moses, you have one person that typed in their chat box that he didn't know addiction was a chronic disease like hypertension or diabetes.
Okay, that's a very good one. That means that we're making progress. Yes, okay. We will not have time for group exercises, as the manual suggested, but we replace the group exercises with individual exercises as we go along because of the medium which we are using to present. And then the number 2 question is, what are some ways you might be able to fight stigma in your community? Beatrice discussed stigma with us in her last presentation, and I'm sure we jotted down some thoughts about what stigma is all about, particularly as regards substance use. So I don't know if you have some thoughts about how you might be able to fight stigma in your community. This is what we are also struggling, and we're doing almost on a daily basis, because it's not just the drug users that are stigmatized. Interestingly, some of us that even work in the field sometimes are stigmatized too, and we also have our own prejudices about people who use substances. So can anyone share with us how you want to fight stigma in your community? A minute, please. Please, can I get any response?
Would you like people to type their responses in the chat box?
Or they can talk, or they type them in the chat box. Then either way, because I want it to be more interactive. Okay, using people first language. I can see Godfrey. He said that using people first language. And then Alero said, I will identify with the persons with addiction. Yes, I can see stigma can be reduced. Or increase awareness in the community. Addiction is a brain disorder, not a moral failure. Stop labeling, okay? And then I will identify with the persons with addiction and explain it to those who care to listen. Right. Many responses. I read one here. Social media is a very good field to fight stigma. I did a page on Facebook with the name of our center, and we published daily anti-stigma and slogans. Thank you very much for your responses. I can see that we all have various ways in which we want to fight stigma in our community. And it's something that all of us should be involved actually as drug use professionals, because it's something that the society is still not, some parts of the society might not accept it addiction as a brain disease, and our clients are stigmatized. So we need to actually advocate for them and fight stigma so that they can come for treatment. Well, let's proceed. Thank you very much for your very great responses. Now, the introduction to Module 5 continues. What by the end of this, we'll be looking at, we'll be able to define and discuss, what the characteristics of psychoactive substances are, and the consequences of psychoactive substance use. There are consequences. So by the end of this module, we'll be able to answer those questions, and then we'll be able to answer the question, how does substance use and addiction affect a person's family? It is not just an individual problem, it affects the family, the community, and society. So, so the main objectives for module 5 are: 1, we describe at least 3 characteristics of drug use in each class of substance use, and then discuss the individual, family, and community consequences of substance use. Discuss substance use in the community, discuss the effects of drug use on the family. When we are through with this module, if these questions are asked, I'm sure all of us will be able to address them convincingly. Now we go to what is a drug. Earlier on we'll be talking about substance use, but now we are going to be talking about a drug, what a drug is, and the drug use. And the definition varies depending on the perspective which one is coming from. In medicine, a drug is any substance with the potential to prevent or cure a disease, or the potential to enhance physical or mental well-being. Yes, if you go to a hospital and the healthcare workers are talking to you about drugs, particularly if it's not an addiction treatment center, your mind goes to any medicine that will cure or prevent disease or enhance one's physical and mental well-being. But if you are talking about pharmacology, which deals with the study of drugs and also their effects, we'll be talking of any chemical agents, that affect the biochemical or physiological processes of body tissues or organisms. So we're looking at a chemical agent, that will affect or change the biochemical or physiological processes of body tissues, not only tissues, but also whole organisms. But if you go to, and you talk about a drug, what comes to the mind is a substance that is used for non-medical or recreational reasons. That's what comes to the public. If you're not outside medicine and pharmacology, you're talking about drugs, people begin to think, oh, maybe they think of drugs of or abuse, particularly psychoactive substances. And I would want anyone can remind us about the definition of what a psychoactive substance is. Who can help us refresh our memory about what psychoactive substances are? Can anyone help us with the definition, please? Remind us again about what psychoactive substances are. If you recall, we dealt with those ones in course 2, so we want to refresh our minds again. Yeah, I'm waiting for your response. Okay, I can see here any substance that can alter the way the brain functions. Okay, any other? Any other definition? Okay, yes, one, any substance that can alter the way the brain functions in mood, behavior, and perception. Okay, thank you very much. Does anybody have any other definition? Yeah, we'll talk about psychoactive substances, altering brain functions, and then they affect our mood. They affect also our behavior, and it's not just the mood, but behavior and the way we also think, or our thought processes. So, and last time, if you recall, we had some exercises in how the brain, how psychoactive substances can alter one's mood. Sometimes can be positive or negative, and we give responses for thought processes too. And we also give various responses, for behavior. And the behavior can be either desirable ones or undesirable behaviors, or positive, negative, changes in one's mood, way of thinking, and also the way in which we behave. Okay, let's continue. And you also recall that we talked about drug classification, and Beatrice helped us to review, the various classes of drug classification. This is what we use for our own presentation, but if you go to other texts, you may find different classifications, but this one is simpler and it's easier for us, to follow. As I said earlier on, this is a multidisciplinary approach to counseling, and we need to lay the foundation for everyone so that we can work together. We talked about stimulants. Stimulants increase the activity of the central nervous system. They tend to increase the heart rate, breathing, and they also need to give us a kind of an excited form of euphoria. That's what stimulants do. But when you talk about depressants and opioids, depressants tend to decrease the activity of the central nervous system, and they decrease the heart rate, somehow the breathing, but they also give us a form of euphoria, but this time it's not an excited form of euphoria, but a calm, relaxed form of euphoria, and some may even go to sleep. And then we talked of opioids, they also decrease the activity of the central nervous system, just like the depressants. But most of them have some sedative effect, and some people tend to enjoy, in fact, the sleep that comes from the use of opioids. I recall I had one very interesting client, a female. She was much more interested in the sedating effects of pentazocine, which she was addicted to, and she used to call it my sweet, sweet penta, because she says when she takes it and then she sleeps, there's nothing like it. So she enjoys the calmness and then the sleep that comes with it. So, but she feels good, but it also puts her to sleep. So this is one of the differences between the stimulants and depressants, and the opioids, which are sometimes called narcotics. Then we also talked about hallucinogens. They produce a spectrum of vivid sensory distortions and markedly alter mood and thinking. When I was in training, I read a book, about one of the psychiatrists who wrote a book on psychopathology. He wanted to feel, and experience what these hallucinogens were all about, and then he tried, taking LSD. He told us that he wrote that the effect was really, really very frightening. A lot of sensory distortions. You could see all kinds of frightening images, and his body became almost like transparent. He saw images coming, penetrating his body from one direction to the other, and it was really very frightening. So these are, vivid sensory distortions that can also alter one's mood and thinking. Can make you frightened, can make you excited, can make you depressed, and depending on the substance that one takes. So in summary, these are the classes that I will talk about. Now, we also talk about some substances which don't easily fit into these classes, sometimes because of the dosage that we use or because of their unique chemical structure. So some of these are cannabis, marijuana, and hashish. Doesn't really fit into one group. And then sometimes it can work like even a stimulant for some, a depressant for some, and a hallucinogen for some, but depending on the dosage that one uses. And then we talk about miraa, which is cat. The Ethiopians call it chat. I worked in Ethiopia for some time, and they call it chat. So doesn't really fit into any group, though it has some amphetamine-like properties. They will have inhalants, solvents, gases, and nitrites. We also have dissociative anesthetics like PCPO, the full name is phencyclidine, and ketamine. I have patients, and most times you find young people tend to combine drugs from different classes. You can find somebody using, for instance, an opioid, and I have several patients who use opioid, for instance, petidine or pentazocine, and then they also take it together with ketamine. Yes, let's continue. Now, we want to have a small exercise which has to do with the characteristics, effects, and health consequences of drugs. And I said this is going to be a very interactive session, and we want you to also participate, but it's not going to be a group because of the medium which we're using. Hence, I want you to attempt to draw a human figure. It must not be you must not be artistic in drawing it if you're not an artist, but you can draw just a live figure on your journal, and then using a few words as possible, help us to indicate the roles of administration, the effects of the drug, the side effects, and medical consequences of the assigned drug or drug class on one of the figures. You are going to draw two figures, but for this one, the first one, you draw the figure and then use a few words, and then as possible indicate the routes of administration. If it's like through the sniffing or is through inhalation, whatever it is, indicate it on the figure, and then also help us with the effects, the brain, the side effects, and then what you think might be the medical consequences of the assigned drug or drug class. And then be prepared to tell us, I will call maybe one or two to tell us which drug they're using on their own figure, And on the other figure, you draw what you think might be the withdrawal symptoms of the drug that you've chosen to use. So it's supposed to be a group exercise, but we are going to do this individually. So please, I give you like 2 minutes to help us draw a figure. Draw a figure, 2 figures. One indicates, name the drug first of all, and then in few words as possible, indicate the rules of administration, effects of the drug on the brain, the side effects that you know, and the medical consequences of the assigned drug, of the drug that you have chosen to use. No one is assigning any particular drug to you at this time. And then in the other one, in the other figure, list the withdrawal symptoms of the drug that you know. I want us to, and you can think of any client that you have worked on before, or if at all you had used it in the past yourself. Please think, try to visualize that time, or either the client or yourself when you used it in the past, and list all these things for us. I'll give you 2 minutes, then you can share. 1 or 2 people can also share with us what they know about the drug and then the withdrawal symptoms. I hope the instruction is clear to everyone. 2 figures you are going to draw. It's an exercise that is beautiful when you do it as a group. There you can be more creative in presenting it, and then you have time to come and stand before the group to present, and then you share, and people can make comments or additions, or if at all they think you've missed out anything, they can add, or they may criticize it, or whatever. But in this medium, we are not able to do that, but you can do it as individuals, and then you'll be able to share with us. You still have 1.5 minutes to finish the exercise. And think of a drug that is commonly used in your area or that you are familiar with, so that it will be easier for you to carry out this exercise. And if you know the street name of the drug, you can tell us the street name in your own environment or your own community where you use the drug. For instance, here, most of the clients who use weed will tell you they call it grass, but they have all kinds of names. In fact, from one part of the city to the other, you find people give it different names. So, but some will tell you grass, some will call it Igbo, some will call it yellow jacket, whatever. So, we want to know also the street names in your own community when you draw the figure, so that we can share ideas and experiences. We have a minute more. Thirty seconds more. Okay, is anyone ready to share with us? If you have any drug that you've chosen, please share with us the rules of administration. Sometimes you find a particular drug may be used, in different ways. For instance, in my own environment, cannabis is smoked. Some people use it as tea. and some use it in their own soup, while some can use it in cake or some other things. So it's used in various ways. So I want to also have experience from other regions. So who is ready to share with us, please? This time you need to talk because we might not get it all in the chat. So if anyone is ready, then Kim will allow you to share with us. Is anyone ready?
You have 2 hands raised. Sanzo
okay,
and
please.
Fatima.
Yes, please.
Sanzo, you want to go?
Yes.
Okay.
Yeah. The substance that I chose is cannabis.
Okay. Good.
Mostly in my country, Malawi, people smoke it as
Okay.
Some of the effects that people usually have, it's red eyes. Some will experience psychotic features. Some also increased appetite, and we have also seen people presenting with a motivational syndrome.
Okay.
Mostly, I would say, as a community in Malawi, would say most of the side effects that people do have, taken as a side effects, is the psychotic features. It's because people be told, you have like a mental illness or whatever, referring to the psychotic features.
Okay.
Some of the street names we have, it's a mostly like a Chichewa name, we call it Chamba.
Okay.
And we also have other Chichewa names like Mutuambala, meaning the head of a bird.
Interesting.
Yeah, and I think the other common ones is the ganja, the weed.
That's good.
Yeah, mostly I know cannabis can have milder forms of withdrawal symptoms, but what we have seen in practice here in Malawi, we don't necessarily have people withdrawing from the cannabis.
Okay.
Yeah.
Thank you very much.
Welcome.
Thank you very much for your great response. It's interesting. Does anyone want to share? Any other person wants to share maybe another drug of choice? Kim said there were 2 hands. Can the other person please share?
Sorry, Fatima, I unmuted you, so you could go.
Okay. Good evening, everyone.
Good evening. Thank you.
Yes. I'm from Zaria in Nigeria. And most commonly, the substance here is codeine. Cough mixtures with codeine. And here they call it Ruwa. Ruwa means water. That's another name for it. They also call it Kush. That's another street name for it, Kush. The side effect it has is that the users are always drinking liquid. They don't want to eat. I think it reduces their appetite. And they always take a lot of fluid. In fact, they mix the cough syrup with codeine sometimes with liquid, maybe juice, maybe in soft drink, mineral drinks. And the withdrawal symptoms, sometimes you see them having muscle contraction. Sometimes you see them having seizures. They will be shaking like they are convulsing. That's so right. This is what I have from my area.
Okay, well, thank you very much. So let's clap for ourselves, please, for your participation and your responses. We'll move on. No break. Okay. Consequences of drug use. As you're aware, individuals may suffer a range of consequences, and these consequences don't only limit themselves to the individual alone, and sometimes there can be medical consequences, and then you have legal consequences, you have social consequences, and you have economic consequences, of drug use. And I want us to also, this is another assignment or exercise that I want us to actually do, because most times we think of the consequences only on the individual who uses the substance, but we don't go further to look at the medical consequences. We don't go beyond that. And sometimes even the clients, they just restrict themselves to using the substance, but they don't know that this thing is affecting other members of the society, their family, the community and the society. Like they don't tend to think of it. And so I want us actually to take maybe a minute to think about the medical, the legal, social, and economic consequences, that can come or arise as a result of substance use. I know we don't have much time, but I want maybe one or two people to tell us either the medical, legal, or social or economic consequences of any drug that they're aware of. It's meant to be an exercise as a group exercise, but we don't have the luxury of time, to carry this exercise. But I'm sure from your experience, you have thought of some medical, legal, social, or economic consequences. So I want one or two people to share with us briefly before we continue.
Moses, I unmuted Fatima. She had her hand up.
Yes.
Okay, please. Yes, please.
Like,
Thank you.
You see, people who use drugs, they always have problem with the law. You see that every time the police is always after them, always being arrested by the police because they find themselves in unusual places. Also, when we talk about social consequences, drug use can affect the families too. The family become dysfunctional, and sometimes they quarrel among themselves because one of them is abusing drugs. And when we talk about economic consequences have to do with, drug habits is very expensive to maintain. The person who is using drug needs money every time. So it's possible for the person to be broke because every time he'll be short of money because he uses his money to buy drugs. When we talk about economic consequences also, it affects the government because sometimes the money the government is supposed to use for other amenities, to provide other facilities, will be used, in taking care of drug use problem. So these are the consequences that I can think of now.
Thank you very much. I see a lot of responses here from the chat. Some says accident and driving under the influence. One says unable to keep a job or seek better jobs. And then alcohol, liver cirrhosis, crime, road traffic accident, marital problems, loss of job. And the medical consequences include organ system damage, liver damage, etc. And then we have medical psychosis with stimulants, social with domestic violence, with alcohol, legal with stealing, to fund drug use, and economic with low productivity, and the mental illness. Thank you very much for your responses. For instance, in my own environment, alcohol is a big issue, and we have, in fact, one of the highest rates of liver cirrhosis in the country. If you talk about liver cirrhosis, most people who develop liver cirrhosis as a result of alcohol use, in my own region, it's actually a very big problem for us here. Because of cultural factors. Okay, please, let's continue. There are different physiological responses really when the gender use alcohol, substances. Compared with men, women tend to develop physical problems related to substance use sooner, and they escalate to addiction more quickly, which is termed telescoping. And that is very true because we know that physiologically women have less water volume compared to the amount of fat they have in their body. So even when they take the drug, the concentration of the drug tends to be higher, amongst females than the males. And also, for instance, alcohol, which has been studied more, you find that sometimes even the enzymes that metabolize this alcohol might not be much in quantity compared to men of the same height and weight, and then you find that the concentration of alcohol in their blood might be higher, so they tend to come down more with organ damage compared to the men. And a lot of the studies actually have been done on the women, and this is one of the problems we have. So I know in the past they used to say calculate in terms of units, and they say if you want to stay safe, women should take lower quantity compared to the men. But now studies are showing that no quantity of alcohol is actually safe. Let's move on. Much of the research on women has been done, as I said earlier, regarding alcohol consumption. But newer research suggests that there's a similar pattern of rapid progression to illicit drug use, and you can see some references there down the slide. And it's very true. For those of us who are clinicians, really you find that when the women come with addiction problems, they tend to have very severe problems. And I recall last time I had a very young lady who came with some addiction to tramadol. She became so psychotic that I wondered whether it was just the tramadol that she used. And she would come out of the ward, fetch water and bring it outside in the open, and then she would take a bath in the open. I would say, what are you doing? Take it back. It's just you bring the water back again and take it, want to take a bath in the open, in the full glare of the public. And at the point she brought the water, and I was really wondering what happened. She was so confused, so psychotic that she brought the water and fetched the water, and she stripped herself and started pouring the water on herself, and everybody was watching. So we had to try to rescue her. And I suppose she was thirsty. She wanted to drink some water, and she peed on her hand, and then she drank the urine instead of even the water that she wanted to take a bath. So she was so psychotic. And then we took her back, and I've been seeing that kind of pattern with women who use drugs. And when she recovered, and then she was confronted with what she did, it was not very palatable to her. She felt so terrible that we really had to cancel her, to be able to cope with whatever transpired. And then studies have traditionally used male subjects. That's very true. And significant gaps remain in knowledge of physiological effects across the continuum of woman's life. And truly, in my own client, I know that some decades ago, when you're talking about drug abuse, apart from alcohol, majority, in fact, 90% of, from studies, our local studies, 90% were, the men. But now, the women are catching up. They are really catching up. So they take everything that the men do now, especially among the younger generation and the students in the higher institutions. It's like they're even competing with each other. So there's need to study, both actually the men and the women, and to find out why this is so. Let's proceed. And then fetal effects. Yeah, we know that drugs effects generally range from low birth weight and developmental behavioral and cognitive deficits when the drugs pass through the placenta in the womb, and affect the developing fetus. And we have witnessed that sometimes I have experienced women who have been using drugs after childbirth. You find that the child might be crying and crying unnecessarily, and sometimes the pediatrician or the neonatologist sometimes find it difficult to know what may be happening to the child. And I've been able to help in a few occasions to tell them that if you had taken the history of the mother very well, you know that this woman has been using substances, and this baby is withdrawing from the effect of the substance, and then we'll be able to to help, because they did everything They couldn't really find why the baby was crying, could not eat, and so on and so forth. But it was just the withdrawal symptoms, in the newborn baby. And then methamphetamine exposure, cocaine and marijuana exposure leads to impaired attention, language, and learning skills, and other behavioral problems. So this is what cocaine and marijuana does, to the developing baby. And then methamphetamine exposure, you find that fetal growth is restricted, and then there may be decrease in arousal and poor quality of movement in infants. And heroin exposure, infants born addicted, yes, they're already addicted right from the womb. Passively, they've been taking the drug from their mom, and then you have low birth weight and important risk factor for delayed developmental milestones. And this is true. And for those of us who are resource poor countries, most times you find that the attending obstetrician and maybe pediatrician might not even think of drug use, but it's up to us actually to really help when we are there to know that these drugs can cause the placenta and affect the developing baby. And then we now go to young people. Early use of drugs increase a person's chances of more serious drug abuse and addiction, because the young person is developing physically, developing mentally, and if they begin to interrupt this developmental process with drugs, it causes so much problem. And the young people also are particularly vulnerable to the physical and social problems related to substance use. And because of their phase of development, they are not really fully developed, and the control center or the prefrontal cortex is not yet fully developed to be able to exercise control over their pleasure-seeking behavior, and they don't have adequate social skills, so they tend to run into problems at school, and also even with the criminal justice system, and may affect their grades and so many other things also with their family members. So then we have physiological responses. There are different physiological responses depending on the age in which the substance was used. We know that development continues even beyond age 20, and you can see from this diagram how the brain develops, and different cortical areas of the brain, showing how the brain matures, from say 5 years to 20 years. You can see the prefrontal cortex is, as you move from the left to right, you see that it's the blue color increases, and usually it starts from the back, the occiput goes towards the forehead, where you have the frontal cortex. So, and the frontal cortex is the site of the executive function, where you plan and you make your judgment, you plan to carry out activities, and they're able to carry them out, and to be able to exercise restraint, control over your emotions and desires. But it's not fully developed. And those who are taking drugs earlier, exercise their reward system so much, they're really getting so activated, and it sabotages the control system, the prefrontal cortex, because it's not yet mature enough to exert control over that pleasure-seeking behavior. So you find them getting indulged in these substances, and then they can easily, graduate into addiction, because there's nothing really to control them. The control center is weaker, so to speak, and that's why you find that a lot of young people have a lot of problems, and these problems not just only with addiction, they can also have other problems, And then there's a small group exercise, consequence of drug use, and it's supposed to be, as we have legal, family, social, and economic consequences, just like we discussed in the last group. So there are consequences. This is supposed to be like a group discussion, but as I said, we don't have that time. Time is not on our side, and we have done a bit of it. So we need to know that drug use doesn't just affect the individual, but there are legal consequences, there are family consequences, social and economic consequences. It affects the individual family. So, and also in the community, You probably know more about drugs and drug use in your community than you realize. The use is common among all ages. In fact, from in my own environment, because of the culture, people start drinking alcohol even when they're age 5 years old. You know, at age 5, people are already drinking alcohol. So it continues that till, you know, the latter life. And it's not limited to one socio-economic group. All socio-economic strata drink, and that affects people. And what drugs are the people you work with most likely to use? In your own environment, or in your own group, maybe a professional group, what are the drugs that people are likely to use? As I said, it spans throughout the age group, and also it goes across all the social demographic strata. But in my own group, for want of time, I will tell you, like, for those of us who are in the health sector, you find that most medical personnel tend to abuse opioids because they have easy access to these drugs. And then after opioids, we have alcohol. This is what, you know, my experience in my own northern part of Nigeria is alcohol and opioids. This is what most of the medical or the health workers, you know, are very prone to using. So I think, and then we are supposed to talk about, no, there's no time to talk about the drugs commonly used for everybody, and then the route of administration or special problems. But for them, most of the opioids are either injected or they take them orally. If it's pentazocilopatidine, it's injectable for health workers. But if it is tramadol, most times, you know, they take the tramadol orally. But the special problems they tend to have is that, well, it tends to affect their workplace. It tends to deplete their, you know, their resources, and most of them come down with a lot of complications, particularly from injection, you know, abscesses, abscesses in the injection site, sepsis, and so many other problems, you know, that they come with. And there's no particular time that we don't have health workers, doctors, pharmacists, or nurses, you know, admission because of drug use, and particularly opioids and alcohol. So I stop here. Maybe if we have questions, we can ask after Beatrice has taken, you know, our own session, because we don't have the luxury of time. Thank you very much for listening.
Thank you very much, Moses, for that elaborate presentation. A very good evening to everyone. We are going to continue looking at what Moses has started. Remember, Moses has emphasized that drugs don't just affect the individual, but they also affect the family. And therefore, we are now going to focus on how drugs affect the family. But before we do that, we're going to try to define what a family is and what a family system is. And just to quickly ask you, what is a system? And I know for those of us who studied some biological sciences, whether in high school or elementary school, we must have studied different types of systems, from digestive systems to all the rest. So can you quickly type in the chat some of the systems that are in our bodies? In half a minute, yes. Please type, and Kim is going to read them out for me. Respiratory system. Digestive system.
Central nervous system.
Central nervous system.
Cardiovascular system.
Cardiovascular system.
Excretory system.
Very good. Thank you very much. Of course, we also have reproductive system and many others. Thank you for your answers. I wish to ask one more question. What is the common thing about systems? What do systems have in common? Let's pick the digestive system, for example. What are the different parts of the digestive system? Please quickly type in your chat. Kim, please read for me.
Mouth. Stomach. Esophagus. And someone answered your question saying that the system is made up of several units. Intestines.
Thank you very much. I think that is good. That a system is made up of several units or several elements, And a good example is the digestive system. You're telling me it has got the mouth, it has got the intestines, it has got the stomach. And so a system has got elements. The other important thing about these elements is that they interact with each other. And for the system to work effectively, each of these elements or units must be functioning well and relating with the other part well. That's why sometimes we get a stomach upset if we eat very quickly and we don't chew well enough, because our teeth didn't do what they were supposed to do properly. And so the stomach then starts to complain. So a system is made up of many elements or different elements. These elements are interrelated. And for the system to function effectively, every part of the system has to be working well. And that's the same with families. We look at a family as a system that has got unique interaction and relationship between its elements. And in this case, the elements are the members of the family. So how the members relate with each other, how effectively they interact with each other will determine how well or how stable or how functional that system is going to be. Now, when we think about a family as a system, there are several elements. Just like the digestive system had the mouth, and it had the stomach, and it had the intestines and the many elements, so does a family system have many elements. And these are some of them. We have got what is called the hierarchy. What does hierarchy mean? Hierarchy means, I think I want someone to just chat for me. What is hierarchy? Yeah, just quickly type what hierarchy means to you. Anything, Kim?
Not yet. Order, organization.
Organization, yes. I know in our organizations we have hierarchies.
Order, seniority.
Seniority and order, absolutely. Thank you very much. When we think about hierarchy, we have to ask ourselves, who calls the shots? Who's answerable to who? Who delegates authority to who? That is what hierarchy is about. And I do know many of you who sit in this class have got very high positions in your organizational hierarchies based on the introduction that I had. And that's the same thing. A family has got a hierarchy. Who is who in the family? Who gives instructions? Who listens? Who seeks for help or for guidance from who? Now, I want an example from, this is Africa. Africa is very interesting in terms of hierarchy in the family. One of the ways you can tell about hierarchy in a family is that you get into some houses or some homes and you discover there is a specific seat somewhere that is reserved for a certain member of the family who gives the orders and where people look up to for authority. What are some of these experiences in your countries about hierarchy in families? Please type in your examples.
Father as the head of the family.
Father as the head of the family. What about mother? What about children? Sometimes you also find that in the absence of the father as head of family, there is someone who takes charge. In some cultures, it's the mother. In some cultures, it's the eldest son, and so on and so forth. We have a certain joke that sometimes I hear in my culture, which I do not necessarily agree with. You visit a home and you ask whether people are in, and you're told, no, it is only the mother and the children. And then you ask, is the mother and children not people? It's because in that culture, the owner of that family, the owner of that home is the father. So that is about hierarchy. And you can reflect about this in the different cultures that are in your countries. The second element of a family is what we call roles. Roles. Who would like to tell us what roles means? And you can quickly chat. Anything yet, Kim?
Responsibilities, duties.
Very good.
Past.
So roles is about, thank you, it's about responsibilities, it's about duties. It's about who does what in the family. Again, you find that in many African cultures, roles are very defined along gender. You find that there is what the father does, there is what the mother does, there is what the male children do, there is what the female children do. And you can reflect about this in your different cultures and reflect on the different ways that the family system does reflect roles. And sometimes definition of roles is so serious that if, for example, in a family, the role of preparing food belongs to the mother, if the mother is not there, people are not eating because the mother has not arrived. And in that culture, you find that the father cannot go into the kitchen to prepare a meal because of how seriously defined and rigidly defined those roles are. You need to figure out how roles are assigned in the different families in your cultures, because all these have an implication when it comes to issues of SUD. The third one is rules. Now, rules has to do with what is right and what is wrong, what should be done and what should not be done. And again, it's good to understand and appreciate that those rules may not be written down. They may not even be spoken, but they are known. Can someone give us an example of a rule that was in their family of origin, that was not spoken or written anywhere, but was followed very strictly? A rule. Yes, please chat in your example. Anything?
Not yet.
Not yet.
Here's one. You have to greet your elders.
You must greet your elders. Aha. So in the family, if your elders walk in, you must greet them. In other cultures, you find a rule that says you must stand up when your elders come in. If you had only one seat and an elder came in, then you have got to stand and give that seat to the elder. These are, or you cannot speak back to your elder. All these are rules. Some may be written, some may be not written. Many are not written, actually. Some may be spoken, some may never even be spoken. But people do know that those are the rules of the family. And you might be surprised. I know that when we were growing up, there were many rules that were not spoken, but we knew them as children. For example, you were not supposed to speak when there were visitors. And if you tried to speak, then there was a way that your mother would wink at you, and that would tell you to shut up, you know? And they were not necessarily spoken. They were unspoken, but we followed them. So you find that families have rules. What should people do, what people should not do. People will tell you that in our house, we don't speak when senior people are talking. In our house, before we eat, this and this has to be done. All those are examples of rules, the do's and don'ts of families. The other one is patterns of behavior. You find that families over time have got consistent ways of behaving. For example, you might find that families have patterns of how do they come into their house. One person shared with me that in his house, there are ceremonies around how they get into the house. If he gets to the gate, there is the child who goes to open the gate. There is the one that receives his luggage. There is the one that does this and the other. Very interesting patterns of behavior, which might look awkward to you when you don't practice them. But for the family that practices them, they have meaning. And we need to be aware of this. And finally, of course, families have what we call interlocking relationships. Interlocking just means they overlap. You know, they are not separate, but they are intertwined relationships. Now, we also want to understand the difference between a functional family and a dysfunctional family. Functional families exhibit certain characteristics. For example, they operate out of love, care, respect, and concern. They create and maintain order, and that is important. I'm sure you have seen families where there is no system. People wake up in the morning, children don't know what to do. There isn't breakfast served by anyone, perhaps because the mother is alcoholic or uses substances. And these are ways in which substances of abuse can disrupt the functionality of a family. But a functional family creates order and seeks to maintain that order through the different elements. For example, the roles, the rules, the patterns of communication, among others. The other important thing about families that are functional is that they seek a balance. Now, this is important. They seek to balance in terms of skills to solve problems and make decisions, in terms of cooperating and working together. The importance of seeking balance is because you don't overlean to any one side. If you're too rigid on any one way, then there is a problem in that family. And therefore, the whole idea of seeking a balance between how we develop skills of solving problems, how we make decisions, how we work together is important. And the final point on this slide says that functional families have clear and noticeable boundaries. Now, for us to understand boundaries, we want to understand something called family subsystems. Family subsystems simply means that within a family, you can see little smaller systems. For example, the father and mother make up what is called the parental subsystem. The brothers and sisters make up what is called the sibling subsystem. So we are saying that in a functional family, there is a clear boundary between the subsystem of the children and the subsystem of the parents. If you find a child who is too close to the one parent compared to the two parents to each other, then you begin to have a dysfunctional family. And therefore, for a family to be functional, the boundaries need to be well defined. They need to be clear. They need to be noticeable. We need to be able to see that these are children or the sibling subsystem, and we need to be able to see these are the parents. But you might see families where you can hardly tell the difference between mother and daughter when they are with the father, or you can't tell the difference between father and son when they are with the mother. This is because the boundaries aren't clear. Now, functional families also have rules, standards, and guidelines that are consistent. I think this is an important point, the word consistent, because if we are not consistent in the standards and rules and guidelines, it means that family members don't know when to behave how or what time to behave in which way, and that brings problems in the family. Sometimes family members don't know what to expect, and you're going to be seeing that families that have got parents who use substances have a challenge of consistency in terms of following rules, standards, and guidelines. The other characteristics is that adults are close, they share authority, and they support each other. This is an important point. So nobody dictates to the other. People consult and engage in some form of democratic ways of existence. Even if the parent is single, they are still confident and they are in charge. That is important, because if they are not in charge, then there will be a problem in the hierarchy in terms of who is giving orders, who is issuing responsibilities, who are people answering to. The other important characteristic is that members share feelings, they negotiate, they disagree without fear of rejection or losing the relationship. That's an important point. It doesn't mean that functional families don't have fights. It doesn't mean that they do not disagree, but it does mean that even when they do it in a way that is mature, and they appreciate each other even in the disagreement, and therefore people don't worry that if they disagree, they will lose the love and care and concern of others. And finally, the last point is that within a functional family, members offer each other opportunities for growth, and they encourage each other to pursue courses that grow them, and also to encourage one another. Now, on the other hand, dysfunctional families have the opposite of what we have described. For example, when problems arise, they don't acknowledge that problems exist. Instead, they do not talk about the problems. So they solve problems by what is called avoidance coping. Sometimes we say you bury your head in the sand. So if there are problems, you ignore, you avoid, you pretend they are not there. You don't talk about them. That is dysfunctional. They also learn not to express emotion and needs for the fear that if they do, they may be rejected. Now that is not good for the family, and it causes the family to be dysfunctional because people accumulate a lot of pent-up negative emotion, which sometimes can actually spill out in many negative ways. They also don't know how to take care of each other's needs, and they learn to become survivors. So they're just surviving through life and through their day-to-day moments, because the sense of security and stability is not there. The other important feature is that they become detached and lose trust in each other. And when they become detached, then you realize that they are not feeling connected. And we said that a good family has interlocking relationships. But in a dysfunctional family, people begin to become detached and lose trust in the family members. They suffer a loss of individual identity. We are saying that even though family members are in a system, each of them is also an individual. And the confidence each builds to grow as an individual actually develops based on the support from the system. And therefore, when that support is not there, people suffer a loss of individual identity. They experience interruptions in their emotional development, particularly for children and youth. And if you get an opportunity to take a course called Family in UTC 14, which is an advanced UTC, you will begin to see more of how this happens in dysfunctional families. And we are saying they focus nearly all attention on a member who may have a problem, whether it's a problem of addiction or any other problem that is in the family. Now, we need to understand that when there is substance abuse in the family, or when we have a substance use disorder in the family, it has a significant impact on the family system. This is because it affects all the elements and the functions that we have described. For example, if we have a parent in the family that has an SUD, you can imagine what will happen to the hierarchy. If it's the father and he's the one who was delegating authority, if it was the mother and she's the one who had certain roles in the family, you can imagine if she has an SUD problem, what will happen to the roles and the rules and all these other things that we have talked about. The other thing we want to talk about is about what we call codependency roles. Now, this is a theoretical way of thinking about how substance use affects families. And some research has suggested that as families try to cope with a member who has a substance use disorder, they emerge certain ways, typical ways, that you can almost identify as patterns of coping. And these are the 5 main ones that have been identified. We have got the enabler, we have got the hero, we have got the scapegoat, the mascot, and the lost child. Now, the enabler, just like the word suggests, is a person who enables substance use, sometimes unknowingly, most times unknowingly, by the things that they do. For example, they will protect the person by making excuses for them. They try to keep everyone happy and act as if everything is fine. A good example of an enabler is a spouse who will call the office to say that their husband is not going to work because they have a sickness, when indeed the husband is nursing a hangover from overuse of a substance the previous night. That is enabling because you're protecting the person from facing the consequences of their drug using behavior. Another common one I see in my country is where you find parents, their sons are arrested because Moses has said that one of the consequences is actually legal. So they get arrested for drunken driving. And when they're in the police cell, instead of the parents allowing them to get charged, they go and find a way of getting them out of the police cell before they are charged. That's an example of enabling behavior. The key thing in an enabler is that they sustain the substance using behavior by denying the person the opportunity to face the consequences of their substance use. That's the essence of an enabler. And most times they do it unknowingly. And we're saying the underlying feelings are inadequacy, fear, and helplessness. Then we have got the person who plays the role of hero. Just like the name suggests, and you can see this picture, this is really a hero. They are celebrated. People think that they are successful and doing very well, but all this is actually masking a lot of hurt that they are going through and negative emotion because of the substance use. So to try and compensate for the family, they will work very hard. They will try to outdo themselves. They will succeed, and they will be praised for what they are doing and what they are. But deep inside, they are struggling with feelings of fear, guilt, and shame. Then we have got the scapegoat. Just like the name suggests, a scapegoat is where people want to throw their excuses. So if there's a problem in the family, we have someone we can blame, and that is a scapegoat. So this one decides to become a rebel. He will make noise. He will divert attention from the substance using person so that he looks like the problem. For example, if it's a young person in school, they may decide to cause trouble at school so that now the father and mother can start coming to school to solve their problem. In the process, they actually tend to make the father and mother talk to each other. But the real problem is their substance use in the family. But they become rebellious as a way of trying to cope with the dysfunctionality in their family. And again, like the others, they also have got very negative emotions underlying their behavior. The other one is the mascot. Looking at this picture, mascot is funny. This is the funny one. This is the one who plays jokes to try and ease the pain of the family. So they will ensure that when there's so much tension, there's so much hurt in the family because of the SUD in the family member, they will come and make some jokes. They will come and entertain you. It could be like what this person in the slide is doing, but the idea is to divert attention from the problem, but by trying to make family members happy. Of course, sometimes it works, but not necessarily in a sustainable way. And underlying those feelings of a happy entertainer is a lot of embarrassment, shame, and anger. And finally, we have got the lost child. Just like the name suggests, this is the family member who decides not to cause any problems to the family, because after all, they have enough problems from the person using substances. And so they make no demands. They can get miserable because even their needs may be forgotten, because they don't want to cause any problems, because there's enough trouble in this family. So they try very hard not to be noticed. They will work very hard in their own areas. They will not share their concerns or talk about their needs, because they don't want to be a burden to an already burdened family by the SUT. The challenge with this child is they can actually have a lot of loneliness, neglect, and anger because of that. And so the idea is we can reflect about the families we work with. Do we come across these patterns of behaving? The point here is that when substance use affects the family or happens in the family, it has an impact within that family. Now, you might want to think that when substance use stops and you have treated your client successfully, then all the problems of the family will come to an end. The answer is no. This is the reason that stress and loss of emotional security occur from letting go of old rules and old roles and old responsibilities. Remember, we said that substance abuse has an impact on the elements of a family system. For example, if the parents were using substances, the family forgot about meal times together. The family forgot about birthday parties of family members. The family forgot about going out together on Sunday or having some routines and rituals that were there. Now, the SUD, the substance using person has recovered. They have come back home and they want to regain that old good life of a functional family. Unfortunately, the family members already adapted themselves to the dysfunctional system. And so they no longer have time or space for this person in recovery. A good example I have seen in my country is where a father, because when he was using substances, he was abusive to the family, they learned to survive. So they would run away whenever they heard he was coming and go and hide in their different rooms. Now the father has recovered and he wants to be the father. He wants to call them to come together and have a meal together. But the children cannot, because they don't know how to do that. They learned to stay away from him for their own survival and safety. So that causes more problems now in the family, because the substance using member has stopped and wants to now bring in a new system, a functional system, but the families have adapted and become dysfunctional in the process. The other example is about hierarchy. Maybe the father was absent using substances. The mother took over the responsibilities of the father, makes decisions in the family, pays bills in the family. Now that the father has recovered, he wants to take over the responsibility of being the head of the family, wants to be the one to make decisions, wants to be the one to be consulted by the children. But the children never learned that. They learned to consult the mother. They learned to, inform the mother of their actions and whatever they want. That can cause a lot of problems again and conflicts in the family. So what we are saying is, even when your client recovers, you need to think about the family, because the family continues with their old destructive roles, with their old dysfunctional roles. They do not know the new roles that they are required to adopt. And therefore, they may have difficulty living joyfully despite the loss of suffering from the SUD. And therefore, we conclude by saying even the families themselves will need help. And therefore, it's possible that sometimes why our clients do not recover and they stay out of relapse is because we treat them, but we ignore the family. They go back to the family. The family is exhibiting the old rules and the old roles and the old hierarchies, and your client cannot cope with that. They get frustrated and stressed up, and they decide relapse is a better way. And so let us focus on also thinking about programs that address the family. And I do know that in curriculum 2 or UTC 2, we're going to be focusing more on family. This was just an introduction, and thank you very much. I hand it over to Kim.
Great, thanks. So we only have a few minutes left, and there's just a couple things I want to tell you. One is right after today, after we get offline, I'm going to send you a link for the post-test and for the evaluation for this course. So you should get that tonight. I'm hoping you can all finish it by tomorrow. And once you've finished the post-test and the evaluation, then I'll send you the trainer's manual for UTC1. So you have the participant manual now that we gave you on the first day, and then you'll get the trainer's manual as soon as the post-test and the evaluation are complete. And we wanted to have a conversation with you about how to do UTC2 and the rest of